the business using RPM and CCM. How many folks, just kind of a show of hands, how many folks are currently in your sleep centers using either RPM and or CCM in some form or fashion, using it to follow your patients, manage your patients? Okay, perfect. Okay, a couple of you. So that's good. Majority of you, this will be new. This really is meant to be kind of introductory, kind of a high level introduction, almost a little bit of a primer to RPM and CCM. Get you guys thinking about maybe different ways you can use it. Those couple of folks that raise your hand, no pressure, I may call on you towards the end and kind of get some feedback about how you guys are using it in your practices and sleep centers today. So about 4 objectives, again, really just kind of high level overview. Obviously, we'll talk a little bit, explain how RPM and chronic care management, CCM, can help extend sleep care beyond the center, beyond the lab. Give you some high level overview of what RPM and CCM are, what they mean, and then, work on, just showing how to recognize the value for both patients and providers when you add these services into your center. And then just kind of start looking at just high level, some practical steps that can be taken to start to implement a program, and even just looking at a couple of sample, high level basic workflows. So again, why does this matter? Obviously, you guys know better than me the data on OSA, right? 22 million plus Americans are estimated to have it. About 80% of those are undiagnosed. And one of the key things here, especially talking about CCM, is many of these patients also have at least one comorbidity, right? How many of your patients that you treat and manage in the lab also have hypertension, also have diabetes, also have, you name it, so the list of comorbidities and the prevalence and the tie-in with OSA is there. So it makes a lot of sense to think about this idea of using RPM and CCM to kind of help fill the gap, right? We know with some of these patients, while you guys do a great job managing the patients in the center, managing them for their follow-ups and everything, there can be with this patient population sometimes challenges though, right? There can be gaps in follow-up. There can be certainly challenges when it comes to adherence with these patients, and RPM and CCM, where appropriate, can really help play a role in that. So, and it's just funny, I was kind of out there talking with Tammy from ResMed, so I think hopefully some of the things we'll be talking about today can kind of dovetail, even though we didn't plan it this way, a little bit into some of the things she was talking about, her talk about the patient journey. And so, it's just funny, we were kind of, talking about that these two talks kind of can kind of mesh together. So if we think about, current care or historic care as far as, the sleep center model versus what it looks like for more of an RPM CCM enhanced model, what are some of those differences, right? So when we think about, the historic sleep center model back when I worked in the sleep lab, which was many years ago, it was largely in-person and episodic, right? So typically it was limited to scheduled appointments. They were coming into the lab, coming into the doc's office or the center, for that interaction, right? We see with an RPM or CCM type of enhanced model, it's not so episodic and in person, it's really continuous and obviously virtual or remote. There's a lot of proactive engagement with the patient, whether that be video calls, phone calls, even messaging. Obviously, messaging plays a huge role. The company I work for, even though we're not in the sleep space, we're in the chronic respiratory space. We do a lot of things in terms of remote management of COPD and chronic respiratory patients. And what we find is a lot of times with that population, trying to get them on the phone these days is tough, right? Robocalls, spam calls, no one wants to answer. But then when we do a proactive outreach via text, we text that patient in advance, let them know we're going to be calling, we have a brief engagement through text, then we're able to actually have a much higher success rate getting a hold of that patient. So just with technology these days, you got to look at all the different avenues that are there for outreach, right? So in terms of, care management, a lot of times it tended to be reactive. It addressed problems when the patients would bring it up. With RPM and CCM, it allows for more of a proactive management of the patient, monitoring the data coming from the connected PAP devices or even some of the other wearable technologies that are out there to start to hopefully identify and spot, problems really before they become a problem, right? Spot it when it starts to become a little bit of a trend. So there's opportunity to intervene a little earlier. Again, patient engagement, a lot of times in the old model, that it was kind of low between visits. There wasn't a lot of engagement, as I said previously, with RPM and CCM. With technology these days, that ability to have kind of almost continuous engagement with the patient is there. And that's what these models allow you to do. So again, RPM, just super high level, basic definition. It is remote monitoring of physiologic data, right? So the P is not patient monitoring, it's physiologic monitoring. So if you're running an RPM program, you need to be getting physiologic data back from the patient that you're actually, that's what's being monitored on the patient. Whereas with CCM, it's more of coordinated ongoing support for patients who have chronic conditions. So 2 or more chronic conditions, OSA counts as one of those conditions. So the overlap with one of their other comorbidities would technically qualify the patient that they could be managed and monitored in a CCM, chronic care management program. And combining these 2 together create the potential for a high touch, high impact model, which is really ideal for managing these types of patients. So again, let's kind of break it down. We'll talk initially about RPM, obviously with the PAPs that have been on the market for years, connected PAPs, you've got access to data, you've got access to, you can track AHI, you can track usage, leak, the various events. But now, and every year, there's more and more smart wearable technologies that are coming out there, whether that's wearable oximeters or other types of smart health devices that can also monitor other parameters. So it doesn't have to just be the PAP data that's being monitored. Not that that's a bad thing, that's providing you really valuable insight, but there's opportunity for the patient if that you need to be monitoring something beyond just the PAP data. There's a ton of wearables that are out there that can make it really easy to monitor other aspects of the patient's care. And then this ability to, enable real-time adherence monitoring. So like I said, being able to spot issues before they become a true problem, right? Let's spot it within the first, 1 to 2 to 3 days of that trend developing versus having to wait till we find out the patient's not used the device for 20 days, 30 days, 15 days. So that ability to be proactive and intervene earlier, a model like this where you're essentially getting paid to do that, can really help drive higher compliance numbers. There's really good data out there from some of these third-party companies that provide some of these RPM services and that partner with sleep centers, where that ability to monitor these patients can lead to higher compliance rates, 30, 40% higher compliance rates longer term, right? Not just the first 90 days of usage, which historically a lot of the DMEs are focused on those first 90 days because it ties into how they get paid, right? For the PAP, and then hopefully get paid for resupply. But then that ability to monitor them for 6 months, 7 months, 9 months, a year, and drive long-term sustained higher compliance rates, that opportunity is there when you're running an RPM style program. So CCM, chronic care management, this is more of a broader care management component. So it's ideal for patients with OSA plus, say, hypertension or obesity or the other comorbidities. So in this type of model, you've got monthly touch points that really drive the goals to keep the patient engaged and address some of those non-PAP challenges. So yes, they're an OSA patient, and you can use RPM to address just maybe those PAP issues, right? But then if they have another comorbidity that qualifies them for CCM as well, then you're also able to address and deal with some of these other kind of non-PAP challenges as well. So the trick with this is, you want to make sure that you're tracking and documenting both in CCM and RPM. It's really about 20 minutes of, 20-minute packets per month. is kind of what you're shooting for. So the minimum bill typically in either an RPM or CCM model is 20 minutes of management per month. But with some of these patients and certain subsets of them, you're going to end up interacting with these patients or dealing, in terms of analyzing the data, updating their chart for longer than 20 minutes. So you've got the ability to have additional billing on top of the initial 20 minutes as well. And it's really about trying to support the patient, keep them compliant on therapy, keep them adherent, drive better quality, better outcomes for the patients over time. So if we kind of look at a feature comparison here with RPM and CCM, really what we're showing here is that with RPM is largely a tech-driven type of service. CCM is a little more kind of service-driven, and so there's that opportunity to blend the two together. So in those patient types where it's appropriate, being able to use RPM and CCM when used together, that allows for both precise monitoring of the patient as well as kind of broad care planning. So it's really ideal for these higher risk comorbid OSA patients. So let's talk a little bit about integration, right? So the first step would be really identifying ideal candidates. This could be done as early as the sleep study or at the PAP setup, right? Identifying some that could be a good candidate for either RPM and or RPM and CCM. Being able to use follow-up visits would allow you to then start to initiate the CCM service if it's applicable, if they have one of those comorbidities. In the sleep center or sleep practice, you'd want to have assigned roles, right? So, whether that's, if there's RTs in the practice, sleep techs, RNs might also be involved, especially on the CCM side, because if you're managing more than just the OSA, you're going to want to have some feedback and some involvement from say a nurse, because you're dealing with more broader issues outside of just OSA, right? So you definitely want to have a nurse under the guidance of the physician that would be involved in a CCM program, right? And really it's just about also making sure that you're aligning any existing patient touch points, right? So it allows you to kind of connect the primary and the specialist, feed them information on the patient, just be that kind of extra set of eyes and ears for them as far as how the patient's doing in the home. And that's really where it starts to really show a difference than kind of the episodic care of the patient going in to see the doctor, is you're really engaging with that patient in that home setting, even though you're doing it remotely. So this is a sample workflow. We've got it kind of color-coded here for the various, there's about 3 different phases to this sample workflow. This particular example is looking at RPM specifically, right? So the first step would be obviously to identify your patient. The sleep physician would identify someone with OSA who's either initiating therapy or maybe they're struggling with their therapy. You have to get obviously patient consent for the patient to be in the program. Obviously, the patient has the ability to opt out if they don't want to be in an RPM and or CCM program, but you get patient consent. They agree to be in the program. They sign up for it essentially. Then they get set up with their therapy, their PAP therapy. In this case, it's an RPM model we're showing. So they get set up with their PAP device, get instructed on how to use it. So that's where kind of the first initial billing code for RPM comes into place, is that initial patient setup and kind of patient enrollment in the program. There's a one-time billing code that gets billed for that. Then as the patient starts off on therapy, you're monitoring the data that's coming in from the PAP, right? The HI, the usage, the leak, the various, if they're on a bi-level, maybe it's also respiratory rate, tidal volume, things like that, if they're on bi-level therapy. But you're looking at that daily data collection that's coming in. You're ensuring that you've got someone that's assigned that's doing regular data review and analysis of these parameters, because that is the key. That's the whole goal with RPM, is that you're not just looking once every 30 days, but you're really monitoring this patient frequently throughout the month, trying to spot any sort of early warning signs, if you will. And then the other key with that, with RPM, is there has to be monthly communication with the patient, right? So And maybe that's just a check-in. If the patient's doing well, no issues, you still need to have some sort of check-in with the patient. There has to be live communication with the patient at least once a month in order to bill under RPM. Now, it is a little gray. There's not a set length of time that communication has to be for. So even though you're kind of billing for 20-minute packets of work, you don't have to be on the phone or on the telehealth call with the patient for a full 20 minutes. That 20 minutes is an all-encompassing time period, right? So maybe you've got a sleep tech or an RT in the practice that's monitoring that patient's data and, you know, looking at their usage, looking at their AHI, making some tweaks or notes in the chart as needed. That needs to be, you know, close to 20 minutes worth of time. And then there needs to be a live check-in with the patient, either phone call or telehealth visit with the patient. And then that combined with the time you spent charting, analyzing the patient's data, that all has to add up to 20 minutes. So if it's someone that's doing well and there's no issues, you still want to do a quick check-in call or remote visit with that patient. But then if it is someone that's struggling, that needs a little extra time, then you can take that extra time with that patient. And that really is the nice thing about RPM is if we think about it from, you know, whether it's being in the sleep lab or being in the DME space, you know, managing patients, you know, we're always kind of pressed for times as clinicians, right? You know, we've got to, you know, especially on the DME side, we need to get this setup done because I've got 3 more to do today. Or as a sleep tech, I need to, you know, I've got 5 follow-ups to do, or I've got patients coming in, or I've got studies I've got to score. So we're always kind of pressed for time. And so, you know, sometimes it's, you know, you get a real complex patient that you end up spending, you know, 30 minutes, 40 minutes talking to either on the phone or in person and having to do some more in-depth coaching, you know, or troubleshooting with. In this type of model, the great thing for that is you get to bill for that time, or your practice or center gets to bill for that time. So if that patient really needs 40 minutes that month or 60 minutes that month throughout the month of interaction to get them on the right footing for success moving forward, you get to bill, or the practice gets to bill for that whole time. So you can really spend the time you need with the patients that need it the most. So that really is the benefit of an RPM or a CCM model, is you've got that ability to drive revenue, but drive it in a meaningful way where it's making an impact in those patients that need that extra level of care. So anyway, sorry, back to my workflow here, right? So, you know, you're the RT, you're the sleep tech, you're doing the data analysis, you know, you're ensuring that you're spending 20 minutes a month kind of analyzing, reviewing, updating charts, having at least one touch point of communication with the patient. Then there's obviously the billing, the documentation requirements. That's all kind of phase 2. That's kind of the day-to-day operational part of the workflow. And then kind of phase 3 is, you know, especially if the program's new, you know, you're going to want to evaluate the program, right? How is this going? What sort of outcome metrics are we tracking? What sort of success are we seeing? You know, set some KPIs. You know, are we seeing better longer term adherence in this patient population that maybe we put on RPM and or CCM than folks that maybe aren't in the program, right? And then there's that opportunity over time to scale the program. So, you know, the big thing about this is with most folks that do this is you want to start small. You want to start with a pilot group, you know, really get the process down, get your workflow down, get the folks that are running it for you from a day-to-day standpoint comfortable with how to do it. And then you can always expand from there. And then, of course, against this backdrop of everything that's going on, you've got physician review and oversight, right? So all of this is happening under the guidance of your medical director, you know, or your physician in the lab in the center, right? So, but as sleep techs, as RTs, as clinicians, you guys are doing the lion's share of the work in the daily work, but then the physician is there to provide oversight and to provide that periodic review also, and also for billing too, right? So All right, so launching a program, right? So again, we kind of talked about this a little bit when we talked about the workflow. The first thing is just, are you guys, is your particular center or practice ready to do something like this? What sort of patient volumes do you guys see? How, from the staff, and the various devices, that get used, are you ready for this? Is the staff, I don't want to say capable, but what's their current workload? Can they take this on? Do you have some flexibility to where you take a dedicated headcount? Because you want, if you're going to really start a program like this needs to, at least in the beginning, you're probably going to want to identify one person that they are the person running this program. This can't be kind of a part-time program that, well, John does this, 5 hours a week when he's not doing other stuff, or Susan adds an hour or two here or there. You really want a point person that really is going to be the person that this is what they're doing moving forward, is they are managing, the data, they're monitoring the data, they're updating everything. So you want that dedicated staff member in the beginning. You also are going to want some sort of, tech partner or platform partner. So again, there's a lot of third-party providers out there. The last slide here would be a reference page where I'll show 2 or 3 of those providers that are out there that provide services. So, again, one of the big key things about this is, from the billing standpoint, is you've got to account and track your time accurately. So there's several different software companies out there now to where you use their platform, you log into their platform, and you're looking at the patient's chart through their platform, and the minute you have that patient's chart open, the timer is started. So you've got accurate documentation if you're ever audited in the future, that you can go back and show, no, in this particular month, we spent 40 minutes with Mrs. Jones and we spent 20 minutes with Mr. Smith. And so you really need that accurate, real-time kind of timer and data tracking. And so there's partner platforms that allow for that. So definitely encourage you to look into that. Obviously, you're going to want to train your teams on the workflow. The workflow is going to be different. Like I said, there's going to be proactive outreach to these patients. You're really looking to head problems off before they develop. It's going to mean also working with billing to get comfortable billing the codes. I'm not a billing expert, but I will have a couple of slides coming up here that show some of the billing codes. But you're going to want to make sure that the billing team is comfortable with that. And like I said, start small. You can always expand from there. Start with a pilot group. Probably start on the RPM side. Don't necessarily jump head first into the deep end and start doing CCM on top of that. Probably start with RPM, would be the logical choice. Then you can add in CCM as you see fit and as applicable over time. So, okay, so you launch a program, it seems to be going well. What are some of the things you want to think about in terms of sustaining the program? We kind of talked about the fact that long-term, medium to long-term, what are the outcomes you're seeing? You're going to want to track some KPIs. Like I said, have you seen CPAP adherence, CPAP usage improve? Have you seen an improvement in patient engagement? Are patients, coming back for the follow-up visits more reliably? Not as many folks, that are no-shows. Are you seeing, over time, better outcomes in your patient population? So some of these kind of, they're kind of common sense things, but they're definitely things you'll want to put down to make sure that you can look back 6 months into pilot or 12 months in, a little longer term, to where you can really show that, hey, no, we're moving the needle in a positive way. It's not just driving revenue, but we're also driving some really important clinical outcomes in our patient population. So, and that can help you sustain the program. So, and again, like I said, with some of these third-party companies, you've got the ability to have real-time alerts and dashboards. It's not to say you can't do it yourself. It doesn't mean you can't just use the manufacturer's compliance platforms to look at their data, but it's a lot easier, if you have a third-party vendor who can be a partner, who they have specialty software to where you have unique dashboards, real-time alerts. A lot of these vendors, or several of these vendors, actually even have agreements with the manufacturers to where that data from the PAP is flowing into their portal. So you're in their portal, meaning your third-party software platform provider, and you might be looking at your ResMed data, or you might be looking at your React Health app data through this third-party portal. That's all tied into RPM and or CCM. And again, documentation, right? So for both compliance and reimbursement purposes, that ability to track your time accurately, be able to show that, yes, we are in the patient's chart, making updates as needed. And then, over time, as the volume increases, you need to have that ability to scale your staff. And maybe the process has to change a little bit as the volume increases. So be anticipating that. We've seen centers that have started to use this have really good success with it. So just, be ready, and, don't be surprised that, wow, this is working, and we're having a lot of success with this. When you implement this the right way, you're going to see success. You're going to, see that, hey, this is something we could scale. So you want to make sure that you're ready for scale when the time comes. So let's talk a little bit about billing. There's a lot of different codes out there for it, but there's, some of these are kind of the primary core codes. So on the RPM side, you've got, like I said, that initial setup or initiation code that you're only going to bill once. That's going to be one time when the patient's enrolled to start. There's going to be a monthly, essentially, data code. That's where you're getting paid for, that monthly transmission of data. And it has to be, 17 out of the 30 days that has to be transmitting data in order to bill that code. And then there's monitoring time, so there's the initial 20 minutes, that's the 99457. And then any additional 20 minutes that you spend in that same month working with that patient or analyzing that patient's data, that's an additional 20 minutes that can be billed. That's that second code you see there, the 99458. So CCM kind of similar. There's similar codes to that. There's 20-minute codes and then additional code that can be used for additional 20 minutes of time. And then there's even CCM, there's even more codes out there. So there's even a complex chronic care management. So depending on, the severity of the patient, you might even be able to bill for even a higher level code. I don't really want to touch on that today. I want to focus more on just the standard CCM and RPM. But depending on, the severity of the patient's condition, there's even a higher level of codes. It's not just CCM, it's CCCM. Not that that's confusing. So, but the thing to keep in mind with this is patient consent's required. They always have the ability to opt out. They can opt out at the front end. They can opt out at any time. And one of the big things is making sure that you're accurately tracking the time and the task documentation. Because in audits, that's really what they're going to want to see. Show me that for these past 8 months on Mrs. Smith that you spent such and such time each month. So that's where some of these third-party software providers really come in handy with their platforms. So again, here's kind of some of those codes I was talking about on the RPM side. So the setup code is the 99453. Your data, your monthly data billing code is your 99454. That's for the transmission of the data on a monthly basis. And again, it has to be transmitting the majority of the time. So I think I said 17 days, but it's either 16 or 17 on the 454, but it has to be, greater than 50% of days the device is transmitting data. So if you've got a patient that for whatever reason loves to unplug their PAP at the end of the night before the thing connects, you're going to want to, that's going to be one of the things you're going to want to troubleshoot to make sure that you're getting regular data transmitted. You got to have greater than 50% of days have a data transmission event with it in order to bill that code. And then again, the 20-minute codes, you may have 1 month, you may have several months where one particular patient is doing fine. Your tech or your therapist is only spending 20 minutes a month managing that patient's chart, but then for something happens, they have a bad month, there's some sort of downturn, and that particular month you end up needing to spend 40 minutes or 60 minutes, broken up over the month, of course, interacting with that patient or resolving issues for that patient. So that, again, that is the nice thing about an RPM kind of billing platform, is that ability to spend the time that's needed when the time is needed in any particular month with the patient, and actually be able to recoup revenue for it appropriately. All right, maybe a little hard to see, maybe not, but this is kind of showing, this kind of breaks it down more into a diagram. You've got that first initial month where you're getting the patient set up on therapy there in orange. That's that one-time code for enrolling them, educating them about the program and the device that they're going on. That's that one-time bill. Then you've got the daily, or excuse me, the monthly data code on top of that. These are the new proposed codes for 26. So that's why you'll see on a couple of these codes down here at the bottom where there's like XX instead of a number showing, because they haven't been assigned their actual code number yet. So this is what's supposed to be occurring in 26. Now, the other thing, I probably should have started all of this off by saying this. I don't know if you've heard of this or not, but right now the government shut down. I don't know if you've heard about that in the news. So right now, telehealth is currently in limbo a little bit. So CMS has told the DMAC contractors to hold on to any bills essentially that they receive during kind of this interim period. With the anticipation being that once the government's back up and running, once there's a CR to get the government back up and funded, that then they can retroactively process those claims. So I guess my point today would be, don't run out and start an RPM program today. Wait till the government's back up and running. Otherwise, you're going to be waiting a little bit to get paid on any of these codes. So, but the good news is CMS has told the DMACs, hold on to the billing. So what, now you got to kind of read between the lines there, but what that seems to indicate is telehealth isn't going away. We probably will see that continue to be funded, but for right now, in this interim, you wouldn't get paid if you submitted bills on this. It would just be held at the contractor level till this thing gets resolved. That's a little different than looking at telehealth. Another aspect of telehealth, the hospital at home. If you guys have heard of hospital at home, where you've got these companies that are now in hospitals where they're actually billing for hospital level care in the home. CMS, before the government shutdown, said to those folks, to those entities, if you've got a patient in the hospital at home program, you either need to unenroll them or you need to get them back into the hospital. So that seems to indicate during this that they're not going to get paid on those claims. So at least on the telehealth RPM CCM side, sounds like there will be some retroactive payment of these codes, but everything's in a little bit of a state of flux right now. So anyway, so point is, these are the codes that should be going into effect in 2026. The nice thing about that is right now, the codes that are in play, it's 20 minutes of time spent analyzing that patient's chart, interacting with that patient. So you got to kind of bill in these 20-minute increments. So if you spend 20 minutes, great. Now, but then what happens if 1 month I spend 30 minutes or 38 minutes? Well, 38 isn't 40, so you can't bill for another 20. So you can bill for the initial 20, but now I can't bill for the extra 10 or the extra 18 minutes I spent. I kind of have to just eat that time and not be able to bill for it. So that's where in 26, you kind of see down here, there will be a code that will allow you to bill for 10 to up to 20 minutes. So it will kind of help meet that gap that's in the current codes where, man, I'd spend 30 minutes a month pretty reliably with, Mr. Jones helping them out, but I'm only able to bill for 20 minutes of my time. 10 minutes a month, I'm not able to recognize that revenue. In 26, once these codes are established, you'll be able to bill for that extra increment that's short of, the second 20 minutes. So, and then again, you can bill that 20-minute packet of time up to 3 times, right? So you can spend up to 80 minutes in any given month working with a patient if you need to. and get paid for those 80 minutes of time. So, so again, and we think that that's really, really helpful for these complex patients and, a certain subset of your patient population where, you spend extra time with a certain percentage of your patient base, right? So now on the CCM side, like I said, there's several different codes under CCM. I don't want to go through all of them. It'll be a little bit of an eye chart up there, and apologize for the light font on this. But kind of think about it like RPM in that, hey, I'm going to spend 20 minutes, the initial 20 minutes per month, and then I'm going to spend any additional 20 minutes I can bill for that extra 20 minutes of time, if that makes sense. So that's why I kind of have those two primary codes up there for you, the 99490 and the 99439. And that 39, that additional 20-minute period, you can bill that as long as it's appropriate. You've got a month where you end up spending, again, 60 minutes, 80 minutes with the patient, you can add that extra 20 minutes on, I think it's 3 times through the initial 20-minute period in any given month. So this is kind of showing you a little bit of an example of combining RPM with CCM. So maybe you've got an OSA patient who also has really severe hypertension, right? So they qualify. So you build the initial enrollment, you bill for the data, because again, RPM, you're billing for device transmission and that $43 base fee every month, and it has to transmit greater than 50% a day. So 16 out of 30 days you need to have data transmission. But then assuming they qualify for CCM, you can then start billing the CCM codes for those 20-minute increments, and it ends up giving you a little extra, about $20 to $30 more per month, depending on how many of those 20-minute packets you're billing. So again, that's why I think probably starting with an RPM program from the sleep side would probably make the most sense. And then over time, when you feel that the team's ready for it and it's appropriate, and obviously if the physicians are on board with it, then you can start layering in with a certain subset of your patient population, CCM as well. So again, I'm kind of spending a lot of time talking about documentation, but that's really important, right? So, depending on your EMRs you're using, you can use some templates that are already in your EMRs. You definitely want to make sure you have patient consent. Best practice is to get consent annually from the patient. So if they're going to be in it longer than 12 months, which most who go on to RPM, it is more of a longer term management. So it's just best practice to annually get that patient consent. And again, lean on some of these third-party software solutions that are out there, providers. They've done a lot of the heavy lifting of designing these platforms that make it easy to track. And in most of these providers, not only are you just tracking your time in the chart, time analyzing the data and documenting, but then built into their dashboard is the ability to text the patient, is the ability to make a phone call to the patient. So now then you're able to document everything, even that remote interaction or telehealth. If you're doing a video telehealth call with the patient, you do all of that inside their dashboards. So it makes it very user-friendly. And then obviously you want to keep care plans updated, especially if you're doing CCM. You want to make sure you got your care plans updated, and accessible, right? So again, kind of benefits to the practice overall, improving outcomes. Obviously, we're talking about revenue, right, from the business side, but the number one benefit is what it can do to drive positive outcomes over time for your patient population. Over time, reduce their complications, not just from OSA, but if you're also doing the CCM from some of their other comorbidities that they struggle with. And yes, increasing recurring revenue. It's amazing the revenue that can build over time in a practice just by implementing RPM. I've got a pulmonary physician kind of colleague / friend up in the Philadelphia area who's been doing RPM now for years, and really just always kind of a little bit of a forward thinker. He's got 400 or 500 active PAP patients that are on therapy. He's got a full-time RT, and he has sleep techs in his lab too, but he's got a full-time RT on his day shift that does nothing but sit there and monitor the dashboards, interact with the patients. He's got really, really strong compliance numbers, really good outcomes, longitudinal over time because of the patient engagement it drives. And then the revenue it's driving, if you do the math on that, 500 patients, times, $170 a month, you start looking at that more than pays for, I think he's up to a couple clinicians now that run the program for him. But just, the revenue can drive for a sleep center is pretty incredible over time. And then again, it helps to strengthen that patient provider relationship. Like I said, you're going to have less of these patients, not willing to engage, not showing up for their follow-ups. And then it's this idea of being able to provide a scalable, provable type proactive program for your patients. So last couple of slides here, especially when you combine RPM and CCM, you've got a real powerful tool for managing some of these comorbid OSA patients long-term, not just for 3 months or 6 months, but long-term management. It's fairly, again, I'm not saying it's easy, and that's probably worded this the wrong way, but it's pretty straightforward in the ability to integrate and get a program started with the proper planning, the proper support. Like I said, there's a lot of third-party providers that can help with some of this and really make what would have been a heavy lift pretty easy. Again, billing and compliance, really, there's a lot of strong billing compliance frameworks to really help. A lot of that's also provided by some of these third-party folks. And again, start small. Make it something that's scalable. Make sure that you're measuring the true impact over time, and then expand when appropriate. So in terms of resources, CMS is obviously a good site to where you can get some really good information around the telehealth programs, the billing specifically, and CCM. And then some of these vendor platforms, I'm not affiliated with any of these vendors. The company I work for, Encore, we're not affiliated with them. We're more on the respiratory side, not the sleep. So I just put a couple of these folks up here. Monetaire has some really good programs. They've been doing this for a while. Vita Sora used to be called Respiri. They rebranded in April, but Respiri is their old name that you may or may not have heard of, but they've got a new name, Vita Sora Health. And then Provounce is another one. And they all have, a platform, software package that they can partner with labs around, as well as just good general information on their sites on how to start programs. So I'll kind of pause there. I know we kind of covered it quickly. I don't know if any of the couple of folks that raised their hand that are doing RPM or CCM in their lab, if you got any feedback. I know this was pretty high level introductory, but does anyone want to kind of talk about what they've seen in their lab in terms of success or challenges in getting a program started? Sure. Mm-hmm. Okay. Yeah. 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 And so just to clarify, are you guys then billing for RPM when you do this? Or okay, and how about CCM, or is that okay? Okay. Yeah, and like I said, right, right, exactly. Yeah, and I agree. I mean, that's why I just feel like RPM's probably your best start to get started with, and then work your way into CCM. But no, and so how long have you guys been doing that now? Okay. 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 Perfect. Okay. Awesome. That's great. That's great. All right. Any questions? Right. Yeah. Yeah. No, that's a great point. I mean, you're right. So, I mean, this is getting billed under CPT code, right? So, I mean, there is going to be a copay associated with this, secondary insurance, so yes, and they're probably already maybe having a copay because of the PAP, so when the physician or the center is billing these codes, there is going to be a potential bill for the patient as well. And so that is part of the reason why you definitely want patient consent. You want to have that conversation up front with them. Hopefully more times than not, though, and you're right, with there's going to be some situations where financially they just can't afford to do it. But hopefully there's enough time, enough frequency that patients see over time that there's a benefit in the program for the patient. But you're right. I mean, cost is definitely something that has to be factored in. You know, and that's really where you want to talk to a billing expert about, are there any financial hardship waivers? I know there's opportunity to do that on the DME side, like a lot of times with PAP, if the patient can't afford, at least under Medicare, the copay or the deductible, there's opportunity, with some DMEs to do some financial hardships to waive that. I'm not sure how that would look or work on the RPM side, but yeah, it is, again, that's part of the reason why you also want to make sure you have patient consent up front. So, because they will more likely than not be receiving a bill for the service too. So, good point. All right. Any questions? All right. Well, thanks everybody. Appreciate it.